Episode 29, Dyspnea After Labral Surgery. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. A 19-year-old Division III women's soccer player goes in for hip arthroscopy for labral pathology at an ambulatory surgery center. She is healthy. There's no significant past medical or surgical history. She has no prior experience with anesthesia. At the completion of surgery, there were no surgical complications noted, and the patient was extubated in the operating room without evidence of laryngospasm. In the recovery room, she presented with dyspnea, labored breathing, and a productive cough of pink, frothy sputum. And her oxygen saturation was 85% on room air. Despite her symptoms, the patient denied chest pain or palpitations. She was initially treated with 10 milligrams of furosemide and 100% oxygen via a non-rebreather mask. She was transferred to the emergency department locally and treated initially for suspected pulmonary edema. In the emergency department, her blood pressure was 73/50, her heart rate was 110, a chest x-ray showed bilateral, hazy, acinar opacification consistent with acute interstitial alveolar edema. Her EKG demonstrated a normal sinus rhythm at 91 beats per minute. An ABG showed a pH of 7.48, a PaO2 of 144, and a PCO2 of 25, bicarbonate of 19, and a base deficit of -3 for you intensivists. Her troponin levels came back elevated. The working diagnosis was negative pressure pulmonary edema related to extubation. I was unfamiliar with that diagnosis, but what it represents is a rare but severe complication where intense respiratory effort against a closed airway causes fluid to enter the lungs. My differential diagnosis: perioperative complications including pulmonary embolism, anesthetic complications including residual neuromuscular blockade, aspiration pneumonitis, phrenic nerve irritation, and bronchospasm. I want to recognize the author, Abigail Wirtz, an athletic trainer in Massachusetts. She published this case report in the Journal of Athletic Training in 2023. I'm Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026, and I hope you will join me on the journey. This podcast is for educational purposes only. Okay, outcome. A 2D transthoracic echocardiogram was performed. It demonstrated a dilated left ventricle, severely depressed left ventricular systolic function with an ejection fraction estimated at 25 to 30%, and trace mitral regurgitation. The medical team elected to proceed with an endomyocardial biopsy, and the biopsy confirmed the ultimate diagnosis of viral myocarditis. The patient was started on dobutamine and furosemide, and she responded well. Her systolic blood pressure improved to 82 within 2 minutes of dopamine administration and eventually stabilized at 100/55. She was placed on bilevel positive airway pressure to correct her ABG abnormalities and improve her dyspnea. She was then transferred to a tertiary care hospital and admitted to the ICU, where she recovered over the next 10 days, receiving ongoing cardiovascular treatment. After discharge, the patient entered a prolonged period of cardiac follow-up. She underwent repeated transthoracic echocardiograms, a cardiac MRI, serial blood work, and Holter monitoring. Approximately 9 months after her initial evaluation, her ejection fraction normalized to 55 to 60%. At that point, her cardiologist provided full clearance for competitive athletics with no activity restriction. The athletic training staff created a gradual 3-week progression back into full participation, but during this training period, she reported episodes of fatigue, shortness of breath, and dizziness. Based on uncertainty from the athletic training staff about her recurrent symptoms, a reassessment by cardiology was recommended. The cardiologist inquired about hydration and palpitations, and then recommended a limited activity restriction from heavy practices or games. Despite being nearly a year out from her cardiac event, the patient remained hesitant to fully exert herself. She participated in practices and weight conditioning sporadically but at lower intensity than her teammates. She did not play in any competitions during the season after the diagnosis of viral myocarditis. She ultimately would return to full participation the following season, nearly 2 years after the initial cardiac event. Key takeaways. Viral myocarditis is an inflammation of the myocardium caused by viral invasion and replication, leading to myocardial cytotoxicity and necrosis. The most common culprits are adenovirus and enterovirus, although influenza viruses are another well-recognized cause. Athletes with myocarditis characteristically present with nonspecific symptoms including fatigue, muscle soreness, increased resting heart rate, and elevated heart rate during exercise. Frequently, they have reduced overall exercise capacity. Several key references, specifically the first two that I've listed, are important. And the first one is the 2024 American College of Cardiology Expert Consensus Decision Pathway, which states that athletes with myocarditis should abstain from strenuous physical activity for 3 to 6 months following diagnosis. Return to competitive sports should be guided by comprehensive cardiac reassessment, including cardiac MRI, 24-hour electrocardiographic monitoring, and exercise stress testing to evaluate for stress-induced arrhythmias. Return is considered safe when all examinations are unremarkable and the patient is asymptomatic. The 3 to 6 month exercise abstinence recommendation is based on expert opinion rather than clinical trial evidence, and whether this minimum period independently reduces the risk of acute cardiac events remains uncertain. I'm going to contrast that last statement with a subsequent joint scientific statement from the American Heart Association and the American College of Cardiology, which was published in 2025. This reference adds that for individuals with myocarditis, resumption of competitive sport is allowed when systolic heart function has returned to normal and no arrhythmia is present, at rest, or with graded exercise. Recent data from athletes with myocardial inflammation after COVID-19 infection suggests that resolution of inflammation can occur in 4 to 6 weeks after diagnosis. Therefore, reassessment for resolution of myocardial inflammation can be considered earlier than 3 months, particularly in athletes with rapid symptom resolution and normal left ventricular systolic function, or those with subclinical myocarditis identified on cardiac MRI. However, this reassessment should occur no sooner than 1 month from initial diagnosis. Myocarditis accounts for 2 to 9% of sudden cardiac death cases in athletes, and fatal arrhythmias may be the first manifestation of disease. Elite athletes may have increased risk for viral infection and subsequent myocarditis due to increased pathogen exposure during travel or competitions. Additionally, elite athletes may have potentially impaired immune function from high-intensity physical activity. Cardiac MRI has emerged as the standard of care for initial assessment and clinical follow-up with T2-weighted imaging, parametric mapping, and late gadolinium enhancement to assess inflammation, edema, and fibrosis. Late gadolinium enhancement indicates inflammation or necrosis, early fibrosis, and a potential arrhythmia substrate that promotes adverse left ventricular remodeling. For patients with insufficient cardiac recovery, an endomyocardial biopsy is recommended to clarify the diagnosis. Okay, practice questions. A 22-year-old collegiate soccer player presents with fatigue, chest discomfort, and reduced exercise tolerance 8 days after a febrile upper respiratory illness. Resting EKG shows diffuse ST segment elevation and PR depression. High sensitivity troponin I is elevated. Echocardiography reveals a left ventricular ejection fraction of 50%. Which of the following is the most appropriate next step in evaluation? A, endomyocardial biopsy. B, cardiac MRI with T2-weighted imaging and late gadolinium enhancement. C, coronary angiography. D, exercise stress testing. E, repeat echocardiography in 2 weeks. The correct answer is B. Cardiac MRI with T2-weighted imaging, parametric mapping, and late gadolinium enhancement is the standard of care for initial evaluation of suspected myocarditis in athletes. It can identify myocardial edema and fibrosis or scarring, which are critical for diagnosis, prognosis, and return to play decisions. Endomyocardial biopsy is reserved for cases with hemodynamic compromise or diagnostic uncertainty after initial non-invasive workup. Exercise stress testing is contraindicated during suspected active myocarditis, and coronary angiography would be considered if acute coronary syndrome were suspected, but the clinical picture here is more consistent with myocarditis. Okay, question 2. A 19-year-old competitive swimmer is diagnosed with acute viral myocarditis with preserved left ventricular ejection fraction at 58% and mild symptoms that resolve within 1 week. Cardiac MRI at 5 weeks shows resolution of myocardial edema, no residual late gadolinium enhancement, and normal biventricular function. Troponin has normalized, a 24-hour Holter monitor and exercise stress tests show no ventricular arrhythmias. According to the 2025 AHA-ACC scientific statement, which of the following is the most appropriate recommendation regarding return to competitive sports? A. Return to competition is reasonable at this time. B. Return to competition should be delayed until 3 months from the diagnosis. C. Return to competition should be delayed until 6 months from the diagnosis. D. The athlete should permanently retire from competitive sports. E. Return to competition requires a normal endomyocardial biopsy. The correct answer is A. So the 2025 AHA-ACC scientific statement allows an early return to competitive sports as early as 4 to 6 weeks in athletes with preserved left ventricular function, provided no symptoms, and cardiac MRI shows no active inflammation or edema. Troponin should be normal, and there are no exercise-induced ventricular arrhythmias in this situation. This answer represents a shift from the traditional blanket 3 to 6 month restriction, and it is informed by the COVID-19 cohort data showing that cardiac MRI inflammation can resolve in as few as 4 to 6 weeks. Okay, question 3. Which of the following best explains why elite athletes may have an increased susceptibility to viral myocarditis compared to the general population? A. Higher baseline left ventricular mass increases viral tropism. B. Intense training causes immunosuppression and athletes may be exposed to viruses during frequent travel. C. Athletes have higher circulating catecholamine levels at rest, which promote viral replication. D. Chronic volume overload from training predisposes to pericardial inflammation. And E. Athletes are more likely to use nonsteroidal anti-inflammatory drugs, which worsen viral myocarditis. The correct answer is B. Elite athletes are at increased risk for viral myocarditis due to the immunosuppressive effects of intense training, worldwide travel exposing them to diverse pathogens, and tendency to exercise during or shortly after viral infections. Vigorous exercise during active viremia may facilitate viral entry into the myocardium and amplify the inflammatory response. While anti-inflammatory use is common in athletes and may theoretically worsen myocarditis, the primary risk factors relate to immunosuppression and exercise during infection. Question 4. A 25-year-old professional basketball player was diagnosed with acute myocarditis 8 months ago. His initial left ventricular ejection fraction was 38%. Current cardiac MRI shows a left ventricular ejection fraction of 55%, no myocardial edema, but persistent late gadolinium enhancement in a mid-wall pattern. He is asymptomatic, and Holter monitoring and exercise testing showed no ventricular arrhythmias. According to current guidelines, which of the following is the most appropriate recommendation? A. Permanent disqualification from competitive sports. B. Return to competitive sports with annual follow-up surveillance. C. Return to competitive sports is not recommended until late gadolinium enhancement has completely resolved. D. Repeat cardiac MRI in 3 months, and if the gadolinium enhancement persists, perform endomyocardial biopsy. And E. Cleared for recreational activity only and no competitive sports. The correct answer is B. According to the most recent 2025 AHA-ACC scientific statement, asymptomatic athletes with residual late gadolinium enhancements suggestive of prior Myocarditis may continue competitive sports if left ventricular function has normalized and there are no ventricular arrhythmias. Late gadolinium enhancement may represent a healed scar rather than active inflammation, and its presence alone in the absence of edema, arrhythmias, or left ventricular dysfunction does not mandate permanent disqualification. However, late gadolinium enhancement is a prognostic marker for adverse outcomes, so annual follow-up is recommended. Question 5. Myocarditis is an important cause of sudden cardiac death in young athletes. Which of the following statements regarding the epidemiology and risk of sudden cardiac death from myocarditis in athletes is most accurate? A. Myocarditis accounts for approximately 25 to 30% of all sudden cardiac death cases in athletes. B. The risk of sudden cardiac death from myocarditis is highest during the convalescent phase, 6 to 12 months after diagnosis. C. Myocarditis accounts for approximately 2 to 9% of sudden cardiac death cases in athletes, and fatal arrhythmias may be the first manifestation. D. Sudden cardiac death from myocarditis occurs exclusively in athletes with reduced ejection fraction at diagnosis. And E. Athletes who survive an episode of myocarditis have no increased long-term risk of sudden cardiac death. The correct answer is C. Myocarditis accounts for approximately 2 to 9% of sudden cardiac death cases in athletes. Fatal ventricular arrhythmias may be the initial presentation, occurring during active myocardial inflammation when vigorous exercise can serve as a trigger. The risk is not limited to those with reduced ejection fraction. Athletes with preserved function but active inflammation are also at risk. Long-term follow-up studies show that the presence of late gadolinium enhancement on cardiac MRI is a powerful predictor of adverse outcomes, including sudden cardiac death even after the acute phase. Thank you.